Oh, no, you're fine. Perfect. Great. Okay.
I moved my office today, and if I were to point you around, it's quite cluttered and disorganized.
No worries. All right. I've already made you co-host, so you can go ahead and begin when you are ready to do so and share your screen.
So I'm going to share my screen for and I think you should be able to see my screen now.
Yes.
See my PowerPoint? Let me
Yes,
close my office door because people are going by. So I was asked to talk about behavioral and psychological symptoms, and I restricted this to neurodegenerative diseases. I think after seeing how many slides I could produce on this subject, I decided that I wasn't going to talk specifically about treatment of these symptoms yet and save that for a later time. But I wanted to tell people how I approached patients that have cognitive issues. And so I'm going to really talk about two things. Whoops. Let's see, this is a little weird. I'm going to talk about the systematic collection of data and the value of it. The first reason is it makes it much easier for me to make the diagnosis. This also identifies the areas of intervention. And just parenthetically, I'm going to say that, in fact, we treat symptoms, not pathology, most of the time now. And so I'm going to talk initially quite extensively about the systematic data I collect. Most of the data that I collect actually is from caregiver questionnaires so that I can focus on the areas that are of most concern to patients and their families. And but there's some general information that needs to be collected. The most important things that I think are needed to be collected are on the next two slides. The age of onset. Family history is also important if the age of onset is before age 62, and in that case you should think about genetics. When it's early onset, I frequently think that patients might be suffering from pseudodementia and having problems, depression and anxiety, or actually have sleep apnea because poor sleep quality can actually interfere with cognitive function. And probably a third of the patients third of the patients I see by myself in my neurology clinic actually are quite young. And it's usually one of these three things: depression, anxiety, sleep apnea, and adult attention deficit disorder. Sometimes, though, I can satisfy myself that I think it's one of these things, but in fact, patients may be detecting early signs of a neurodegenerative disease, and they are more sensitive to detecting problems than oftentimes we are with formal neuropsych testing and my bedside testing that I routinely do. The next thing that's really important to understand is rate of progression. Slow rate of progression oftentimes means that there's an atypical dementia. It could mean limbic predominant age-related TDP-43 encephalopathy. That's a mouthful, and so it's called late now. This is a relatively recently described phenomenon. It also can be dementia with Lewy bodies, and it also can be the worried well, or people that have very early symptoms and can detect these symptoms. Fast progression usually makes me think of medical conditions such as metabolic, hypoxia, hypoperfusion, viral syndromes, even prion diseases, or autoimmune and paraneoplastic disorders. Episodic versus steady progression usually is an indication to me, if it's episodic, that vascular disease may be involved. Another thing that's worth asking about, but I rarely get a straight answer from my patients, is whether they have much better days than others. Fluctuations in cognitive performance suggest a diagnosis of dementia with Lewy bodies. And also drug use is important. There are a number of drugs that interfere with cognitive function, particularly anticholinergics, opiates, and antipsychotics. Anticholinergics are widely used by older patients as for insomnia. Most of the over-the-counter sleep aids include diphenhydramine, and in fact, a few years ago, both a Chicago group and a Seattle group demonstrated that from epidemiologic studies that use of chronic potent anticholinergics such as Benadryl increase the risk of developing Alzheimer's disease. And it clearly can interfere with cognitive function in the short term. So this is the beginning of a section I'm going to talk about my CNS informant screen. I actually modified it a teeny bit based on other people's suggestions recently, and so I haven't incorporated this exactly into my own clinical use, but this CNS informant screen actually is oftentimes enough to get me in the ballpark of a diagnosis. So the first section is on cognition. Difficulty remembering recent upcoming events, repeating questions and stories, getting lost or not knowing where the patient is, keeping track of time, finding the appropriate words, and difficulty making decisions. By and large, it's really, really important to collect this information and to know which of these symptoms are first. If these are the first symptoms, you know, the things that one would start to think of is Alzheimer's disease versus, if language is the predominant thing, one of the language predominant neurodegenerative disorders, which I'll talk about later. The next thing I want to know about is whether people are sad, depressed, anxious, worried, tend to fidget, are more impulsive, and are withdrawing with less interest in hobbies and social activities, and whether they hear or see things that are not there. In general, if this was marked as severe for many of these things and memory was relatively mild, one would start to think of frontotemporal dementia. If one was seeing or hearing things, then that was an early sign. One would think of dementia with Lewy bodies. Social cognition is also a common problem. It usually isn't the first problem in most patients except those with frontotemporal dementia. Motor symptoms can have a major impact on patients' quality of life, and some of these things can give you a clue that they may suggest other causes of disease, neurodegenerative disease, besides the most common causes that we see in clinic. For instance, if the first problem was walking difficulty or falling, you would leap to the conclusion that I should think about progressive supranuclear palsy. The other motor functions tend to make me think about Parkinson's disease, dementia with Lewy bodies, and Parkinson's disease with dementia. Swallowing difficulties in particular and speech changes make me think about the neurodegenerative disorders related to language problems. So learning about the instrument of activities of daily living can tell you a lot about how that people are doing. When these things are the very early signs of the earliest symptoms, then I would start to think more about Alzheimer's disease than most of the other conditions. So the last areas are basic activities of daily living. If these problems are the very first problems, again, I would think about frontotemporal dementia. If vegetative problems are particularly important, part of the early condition, it can lead to a range of diagnoses, and this area should be investigated much more systematically. When I think there's any sleep disorders, I use a circadian rhythm sleep inventory, which enables me to make a suggestive diagnosis of REM behavioral sleep disorder, periodic limb movements, and sleep apnea, which are the three most common issues related to neurocognitive disorders. The reason why I am so interested in which symptoms come first in patient is first symptoms predict pathology. That's because first symptoms reflect where the pathology started, and the defined pathologies tend to start in a specific region of the brain. But as neuropathology progresses, systems become less specific. In fact, I'd go as far to say is typically when I see patients with late disease, all the conditions that I commonly diagnose sort of look the same. So I'm going to go through, sort of a summary of the first symptoms that predict disease based on the frequency of which I make diagnosis in my behavioral neurology clinic. So Alzheimer's disease is, of course, by far and away the most common condition. It's becoming a little bit confused, and I'll explain why in a minute. Generally it's late onset after age 61. The first symptoms are invariably cognitive changes, and I've relisted the things that I had on my cognitive screening test. Behavioral symptoms tend to be later, but truthfully, when I see, have patients that come to me to talk about problems, they don't notice things till they notice things, and then they invariably say, frequently say that nothing was going wrong till 6 months ago, even when it's obvious that the degree of cognitive function must have been going on much longer if it's Alzheimer's disease or the most common neurodegenerative disorders. And so it becomes a challenge when they tell me that to decide whether I think, in fact, this is a rapidly progressive disorder. Alzheimer's disease very frequently coexists with three other types of pathologies: strokes and microvascular disease, TDP-43 aggregated protein and Lewy bodies. A colleague of mine, Helena Chu at USC in Los Angeles, had program projects for years trying to identify patients with pure vascular disease, and in fact can almost never find a case of pure vascular disease. In fact, patients with cognitive difficulties that have strokes and microvascular disease typically also have Alzheimer's pathology, which is the predominant cause of the cognitive difficulty, can be hard to deduce. Another thing that's going to be increasingly commonly talked about is TDP-43 pathology. In a recent autopsy series of patients with Alzheimer's disease, half of them had also TDP-43 pathology. And we'll talk about this more in a minute. Lewy bodies commonly co-occur with Alzheimer's disease, and we'll talk about that more in a minute. So vascular, I was talking about vascular disease, and in fact, pure vascular dementia is very rare. And in fact, the old neuropathology papers from the 50s and 60s described Alzheimer's disease as a microvascular disease. The symptoms of vascular disease are quite variable. They oftentimes have the same cognitive problems that Alzheimer's patients, but they're more likely to have executive dysfunction and behavioral problems. When one hears about a patient having a history of strokes, cardiovascular disease, and diabetes, it's a pretty safe bet that they probably have a combination of Alzheimer's disease and vascular disease. So all the things that I've talked about so far are in rank order of how often I make a diagnosis. This next diagnosis is something that's going to confound me and my colleagues for a long time, and it's actually quite controversial. This limbic predominant age-related TDP-43 encephalopathy, or late, is currently a pathologic diagnosis. In late disease, there's some characteristic MRI findings, particularly hippocampal sclerosis. And there's oftentimes atrophy and T2 changes in the hippocampus, temporal lobe, and white matter. It usually starts in the amygdala, but that's actually relatively hard to define on MRI scans. It generally is late onset. The characteristic thing that's the most common thing that I've learned about it is that it has very slow progression. And as Alzheimer's disease is, cognitive changes are the most common. Behavioral symptoms follow. You know, as I say, it most of the time exists with coexisting Alzheimer's disease pathology. And so Alzheimer's disease clinically is sort of being divided now into pure Alzheimer's disease, combined late and Alzheimer's disease, and late alone. There is one thing that has been learned so far from the neuropsychology studies that have been described, and there are precious few of them since this condition has only really made it to the literature in the last couple of years. Late with Alzheimer's disease is said to be less likely to have behavioral symptoms. Both pure Alzheimer's disease and pure late are thought to be more likely to have behavioral symptoms. Why the combination would tend to be protective is totally unknown. So the next most common diagnosis that I make is dementia with Lewy bodies. And I think this needs to be thought of a little bit different than most people typically think of it. Alzheimer's and Parkinson's disease with dementia are on a continuum. The disease that's most frequently diagnosed as dementia with Lewy bodies almost always has Alzheimer's pathology. That patients with more pure Lewy body disease tend to have Lewy bodies distributed in the midbrain and the lower parts of the brain. When it's restricted to just the substantia nigra and the locus coeruleus, we would expect it to make a diagnosis of Parkinson's disease alone. And so this continuum, I think, actually causes confusion when we talk about it. And so, you know, I tend to restrict the diagnosis of dementia with Lewy bodies with the patients that also have usually Alzheimer's pathology, because that's by and far the most common. Pure Lewy body in the cortex is actually strikingly rare. The first symptoms of this condition characteristically are REM behavioral sleep disorder, and this can oftentimes begin years before people have other symptoms. It's widely described that the people have cognitive fluctuating symptoms. Visual hallucinations occur in about 70% of patients that are eventually diagnosed with this condition. In fact, visual hallucinations usually are not an early feature of the other neurodegenerative disorders. They tend to reflect more severe disease. I generally think of visual hallucinations as a release sign when the regions adjacent to the visual cortex are affected. I think it leads to the brain sort of making it up. Most people don't realize how good our brains are at making up stuff. Any person that's ever taken their kids to see the Grand Canyon or like that are usually dismayed when they get out of the car for a minute or two and then get back in the car. And the reason why they do that is our brains are very good at sampling information and then creating the illusion that we've seen it all. In fact, it's really easy to demonstrate to yourself. When I ask patient, try to prove this to someone, I either ask them to look out the window for a minute or two, or tell them I'm going to ask questions about the room that they're in. And when I ask specific questions like how many trees are close to the window, or how many lights are on the ceiling, they'll have no idea. And the reason why is our eyes sampled the room and we said, oh, this is a doctor's office, or this is a typical outside, typical street scene outside our office. And we sort of make up the rest. If we had the difficulty of trying to have to remember everything about our environment around us, it would actually be an extensive burden. And that's actually a feature that's common in patients with autism. They don't have this ability to generalize and extrapolate very well. In general, executive dysfunction, memory and planning and visual functions can be a problem. I commonly use the MoCA to diagnose, to evaluate as a screening instrument my patients. Patients with dementia with Lewy bodies fail at Trailsby cube drawing and drawing a clock quite regularly. If they're going to fail at anything else, it'll be memory function, so delayed recall. Depression, apathy, anxiety, delusions, and paranoia are also common. The motor symptoms are typical of that of Parkinson's disease, but those may actually not emerge initially. When I'm trying to teach people about dementia with Lewy bodies, I often use an instrument developed by James Gavin called the Dementia with Lewy Bodies Composite Risk Scores. It's basically the sum of items and the items listed on the left here. Slowness or hesitation, rigidity, poor balance, rest tremor, daytime sleepiness or lethargy, illogical thinking, staring, visual hallucinations, acting out dreams, and orthostatic hypotension. Based on Dr. Galvin's analysis, when you use a cutoff score greater than 3, it can distinguish with dementia with Lewy bodies with an area under the curve for a ROC analysis of 0.94, a sensitivity of 0.94, and a specificity of 0.78. Dementia with Lewy bodies versus all other cause of dementia, surprisingly, they actually think it does better because it's most often confused with Alzheimer's disease. But of course, it usually has Alzheimer's pathology co-occurring. MCI DLB for MCI AD, it actually is completely sensitive and has modest, pretty good, but not perfect specificity. You would notice that this list doesn't describe fluctuations. And of course, some of this has to be evaluated on exam. So the next most common diagnosis for me is behavioral variant of frontotemporal dementia. And this condition is markedly increased in behavioral neurology clinics compared to a private practice. It is much less frequent than Alzheimer's disease or Alzheimer's disease plus stroke or Lewy body disease, but these are the patients that get referred to me because they're strange. It's, the characteristic major features are dysexecutive function, loss of empathy, and loss of inhibition or abulia. Characteristically, it begins at a younger age, And they've oftentimes alienated their family because of things that they do. It's a very characteristic of patients with this condition to behave like a jackass. Um, the list of, sort of more specific findings that are seen in this, with these major symptoms are, being less cooperative, difficult to get along with, saying hurtful things, and become less concerned about addressing behavior, and poor planning. Hypersexuality is also not uncommon. About 9 months ago, I saw a young woman with early onset behavioral variant frontotemporal dementia when she was brought to the clinic by her friends that worried about her. She was unable to hold a job anymore because she kept on losing them for being unable to plan and follow through, and also saying things to her bosses that she shouldn't. She started volunteering at the USO, and she gave extra special service to the men that sought help from the USO. And her friends were worried about that she would get hurt. It's actually pretty common for men with this condition to also touch women that they don't know in inappropriate places and get into legal trouble. In a lot of ways, this condition resembles Kluver-Bucy syndrome, which is caused by removal of both frontal lobes surgically or as a result of traumatic brain injury. When it's seen in animals, after surgical resection of the tip of the temporal lobes, there's hypersexuality, loss of inhibition. They get in people's faces. They try to eat inanimate objects. They're very hyperoral. In humans, it's usually not so dramatic, but one of the sort of things that makes people like me go, aha, is developing a sweet and carbohydrate preference with weight gain. It is not actually uncommon for people to just keep on eating because they're disinhibited. They lose the sensation to stop eating. And so they eat until it's gone. They can also drink alcohol till it's gone. Many years ago, I mapped the disease gene, the first disease gene for behavioral variant of frontotemporal dementia. And the family I took care of tend to be barkeepers. They tended to dance on tabletops, and they were the life of their party in bars. And they tend to get very, very drunk because they would basically drink till it was gone or they couldn't walk anymore. Now I'm going to talk about the language dysfunction presentations. The most common one that I see is logopenic variant of primary progressive aphasia. This condition typically is, thought of when they have slow speech. They pause when they're trying to think of words, but they maintain the meaning of words. Later in the disease, they have trouble understanding complex sentences because they basically can't store all that information. And by the time that's happened, they usually have severe memory problems also. Relatively speaking, this, behavioral disturbance is less common in this condition. The most common pathology seen in logopenic variant of primary progressive aphasia is Alzheimer's disease. And so the features of Alzheimer's disease eventually develop. Characteristically, the disease progresses a little bit more slowly than Alzheimer's disease. The second most common cause of language dysfunction that I see is non-fluent variant of primary progressive aphasia. These patients lose expressive language. They often have trouble with pronunciation. They have altered speech with slurred speech, and they have trouble putting sentences together. In a lot of ways, this is kind of like Broca's aphasia, where the mechanics of making words just don't work. They can understand the words and they can visualize them and even write them, but they just can't do the mechanics of it. Not uncommonly, this disease progresses to the behavioral variant of frontotemporal dementia. So the loss of executive function and developmental loss of empathy and disinhibition are not uncommon in this condition as the disease progresses. The last disease that I commonly see, which is quite a bit less common than the other, is semantic dementia. And this is a rather striking condition when you see it. Patients lose the meaning of words. They have difficulty finding the right words, and they frequently substitute words like a dog for a cat, and they use vague speech to sort of speak around things. They also have problems reading and spelling, and part of this is they've lost the meaning of words. As the disease progresses, they characteristically can't recognize objects and faces. And this condition can either be due to Alzheimer's disease pathology or behavioral variant frontotemporal dementia type pathology. And as the disease progresses, it can more look like Alzheimer's disease or more look like frontotemporal dementia. So in summary, late stage dementias are very hard to distinguish. The early symptoms are likely to predict pathology, and caregiver questionnaires can be very valuable sources of information for the differential diagnosis of dementia. If anyone's interested, they can get the copies of my screening questions that I give to caregivers by contacting me at my email address at RNI at West Virginia University. And with that, I'll be happy to answer questions.
Thank you so much. That was very informative, and you did an excellent job with that, Dr. Williamson. We did have a question come through, and it's to describe what are REM behavioral sleep disturbances.
Sure, I'm sorry. With so much to tell you about, I slipped over some things. So, characteristically, in REM behavioral sleep disorder, people will act out their dreams. They won't be aware that they did this. They can thrash around, run. They can even try to strangle their bed partners. And so it's, a condition that people sort of laugh about when they talk about it. But if someone ever, throttles their bed partner, it's much less funny. And so usually when this happens, I recommend trying to prove that they have this. So in case the question ever comes up, whether when they throttle their bed partner, that it was not volitional. I'd like to try to document it, but characteristically, it's very hard to get that type of sleep study paid for by the insurance companies. REM behavioral sleep disorder, part of the reason that it happens is normally during sleep. The first stage of sleep that happens, and the reason why we fall asleep, is the accumulation of the chemical adenosine in the brain. If you've ever felt so tired that it actually hurt, you just had to go to sleep, that's because of adenosine. And in fact, it's almost gone within, well, it usually is all gone within 45 minutes of falling asleep. And that's why a sleep can be so restful. If you've ever pulled off the freeway and slept for a few minutes and felt like you could go on, the reason why is the adenosine was gone. But later in sleep, we go into cycles of sleep that go deeper and deeper into sleep, and then it's followed by REM sleep. And in REM sleep, it stands for rapid eye movements. And the reason why there's rapid eye movements is that you're dreaming and your brain is very active, but your body has been paralyzed by the release of glycine on the motor neurons of the spinal cord, except for the ones that control eye movements. And so in REM behavioral sleep disorder, it's actually sort of a normal dreaming stage, but the patient's body hasn't been paralyzed by glycine. There are other sleep disorders that are fascinating, including some patients that still are paralyzed after they wake up, and that can be exceedingly frightening. But REM behavioral sleep disorder is not uncommon, and it may be a harbinger of Parkinson's disease or REM or dementia with Lewy bodies. And the treatment of choice for this actually is melatonin, which is the thing that helps us sustain sleep through those cycles when we almost wake up. It's actually pretty normal to almost wake up 4 or 5 times a night. Some people don't remember them, some people do. When I do it, I start dreaming and thinking about my daytime activities and have trouble getting back to sleep. And because I'm an old man, I usually have to go pee. And so characteristically, you can reduce those problems if you take melatonin.
Thank you so much. Absolutely. I have to take it sometimes just to sleep, but I get really weird dreams when I take it, so I try not to take it every night.
But you know, I don't know if the melatonin is causing the weird dreams.
It's probably me.
Characteristically, it helps people sort of sleep through them and not remember the dreams.
Yeah, it's just opposite. I have to sleep with the TV on, so I'm a mess when it comes to sleep. So.
No. You're not supposed to do that. In fact, because sleep problems are so common in my patients, about 2 years ago, I did almost 100 hours of continuing medical education about sleep. And it's a fascinating subject. I always thought it was kind of boring, i.e. it would put me to sleep, but it's actually much more interesting.
No, I think it's interesting.
And it turns out that poor quality sleep is one of the major treatable things that we can do for our patients.
That's interesting. Does anybody else have any questions or comments they would like to make?
I don't have a question, but I wrote down something that resonated with me is when you were talking about symptoms starting to look the same as later in progression. And, you know, some of the work that we're trying to do with health systems and primary care providers is to start having these conversations early to identify when there might be cognitive impairment, to get to that diagnosis early. And I think that just is another reason of why we should have these conversations early. The later a person gets in progression, the more difficult it could be to narrow down the specific disease.
You know, in some ways, I would say that getting the specific diagnosis has been a little bit sort of an intellectual exercise, because we actually treat patients and their symptoms, not the disease right now. With the recent FDA approval of aducanumab, we're sort of rethinking that. And that's a whole nother subject in itself that I'm not going to delve into right now. But you know, I would say, you know, getting early treatment can help an awful lot. As an example, specifically, oftentimes patients don't report that they're having visual hallucinations to their families. And it's only when I ask them that I learn about that. And it's kind of shocks family members. And, you know, it turns out, you know, that's when it occurs without them knowing it, frequently that's because of dementia with Lewy bodies. And in fact, dementia with Lewy bodies actually responds really well to treatment, and it responds better and longer than typical Alzheimer's disease. And the hallucinations, if they're left untreated, can sometimes lead to the state where it's impossible to treat them without major antipsychotics. And so I'm all in favor of early diagnosis. The other characteristic way that they come about is that patients with Lewy bodies are, the cognitive symptoms are often recognized by primary care, but, and so they prescribe donepezil or Aricept. And it turns out if you give it Aricept or donepezil in the evening, you'll make the hallucinations much worse, and you'll cause more disturbing and dreams with possible increase of REM behavioral symptoms. And in fact, if you just change to giving it in the morning, oftentimes they go away. And so there's a lot to learn about this and a lot that primary care could benefit from. Characteristically, most people know about giving memantine and donepezil or one of the other cholinesterase inhibitors, but primary care providers frequently don't like to deal with the cholinesterase inhibitors like donepezil because of the side effects. And it often makes one of the best things in our arsenal to help cognitive symptoms. It takes it off the table. Most people, think Aricept and /donepezil improves cognitive function by improving memory. That's actually not really what it does. It's much better at helping people pay attention and focus. The cholinesterase inhibitors increase acetylcholine, and probably their major effect in the brain is to bind to acetylcholine receptors, and particularly the nicotinic acetylcholine receptors. And I don't know how many of you here have smoked. I've never been a smoker, but if you talk to college kids that smoke, when they're studying for exams, they really pump up the amount they smoke because they can concentrate better when they're tired and learn new things. In fact, airline pilots fought very hard to be able to smoke in their airplanes because they have a job that's very boring, but they need to pay attention. And, it's also been reported that the incidence of Alzheimer's disease is lower in people that smoke. They probably die a lot more because of cancer, but those drugs are quite interesting. I'd also say that sort of follow on to your comment is the things that make patients end up in nursing homes is not because of memory. It's because of behavior. And, both memantine and donepezil and the other cholinesterase actually have an effect on behavior. If you see how it affects people, the best way to measure it is to give the neuropsychiatric inventory, not to give a mini mental. And so that's where you see the differences. So I'm sure I've gone over time. Is there any other questions people have for me?
You actually haven't. You have 7 minutes left, but we can always give you guys back time if you don't have any further questions. You just let me know.
All right. Thanks everyone for their attention.
Thank you so much for presenting today. So just have one announcement before you hop off. Our next session will take place on August 3rd, and Dr. Navia will be discussing advanced care planning. All right, everyone. Thank you so much. You guys have a wonderful day.
Bye-bye.